as you know, this is one of a series that we have been doing. I'm Dr. Jean McLeod, so I am the Director of Quality and Research and Standards Department for the college, and I'm very pleased to be hosting tonight's session. I'm going to go through some housekeeping very briefly for you. Bear in mind, please, that all our speakers are delivering their talks remotely. We hope that there won't be any technical issues, but do bear with us if there are any problems. Slido will be used throughout the talk, so you can participate by adding questions to that. If you go on to slido.com and use our access code, which is #RCPE COVID-19, we'll do the best to get the answers for any questions that we don't have time to go through onto our website and education portal. We're continuing to run our updates weekly on Thursdays, and they evolve as the situation evolves. We are using the questions that you submit on Slido to inform the topic of each update, so that hashtag will remain open, and please continue to submit questions on that to guide how we design and develop these events. The talks that we have, including tonight's, are being recorded and should be available on our education portal by the end of Friday. You can claim CPD, which is always very important, by completing the online feedback survey, and you'll find that on the college event page on the website. You've got until 9 o'clock on the 28th of May to complete that. And we're aiming tonight to finish the event before 8 o'clock so that those of you working in the UK get that chance to hear the clap for carers, which I would definitely emphasise is very well earned and deserved. And just a headline update on next week's COVID-19 update. That will include Professor Timothy Spector, working in genetic epidemiology in London, Professor Tom Solomon, who's working in NIHR Health Protection Research Unit in emerging and zoonotic infections, and Stuart Ritchie, who is one of my colleagues in diabetes and endocrinology, currently working at the Western General. If you do want to catch up on any updates, they're in the education portal, and you will find some other clinical resources and podcasts covering a variety of topics, including social care and the ethical decision making that we are all going through at the moment. So moving on to tonight's session, I am very pleased to welcome Eleanor Riley tonight. She's Professor of Immunology and Infectious Diseases in the University of Edinburgh. She's actually a vet by training, which is slightly unusual for our college, but her first degree was in cellular pathology and her PhD is in immunology and parasitology. She's got more than 30 years experience as an infectious disease immunologist, with experience both in London and in the Gambia. She returned to Scotland in 2017 and took up her current post in the Institute of Immunology and Infection Research in 2020. She works in the Council of the MRC and is serving on the UKRI COVID-19 Task Force and the MRC NIHR COVID-19 Rapid Response Funding Panel. You can imagine that there are lots of ideas at the moment on what research we should be doing in this area, so I'm sure that that funding panel is being stretched. So without further ado, Eleanor, please join us.
Thank you very much, and thank you for that introduction, and thank you to everybody who's logged in to listen to this. I should say that I am not an expert in the immunology of COVID-19, but in my defence, I don't think anybody can claim to be an expert in this area at the moment. So I have put this together using my own expertise more generally and by continually trawling for everything new that's coming out and being published. And there's an awful lot of it. And just keeping this presentation up to date was actually quite an effort. So I may have missed a few things, and if I have, I apologise. So the talk will be in 3 parts. I'll start with an introduction to the immunology and immunopathology of COVID-19. Then I'll move on to the topic of serology, which has been exercising an awful lot of people in the UK in recent weeks. And finally, in a slightly more positive vein, onto the development of vaccines for COVID-19. Just a minute, my slides don't seem to be moving forward. Sorry. Oops. Oh, there we go. Okay, sorry for that. So just so we all are up to speed, just a very brief introduction to SARS-CoV-2, the virus that causes COVID-19. As we all know, it's a coronavirus. It enters the body by attaching to a receptor called ACE2, which is expressed on epithelial cells via its spike protein. The virus then causes the cell to invaginate. The virus is taken in a vesicle, which then fuses with the virus membrane, releasing the viral RNA into the cell cytoplasm. The viral RNA is then translated into virus proteins, virus assembly occurs, and the virus then buds from the surface of the cell. The immune response that is we expect to be developed against SARS-CoV-2 starts when the virus is taken up by antigen-presenting cells, which then present small viral peptides to T helper cells, and these cells then collaborate with B cells to ensure that antibody is made, and cytotoxic T cells, which in theory at least can destroy the virus-infected cell. And as part of this response, we hope and expect that long-lived memory cells will be developed, which will give us immunity in the months and years to come. Sorry, the slide change is being very slow. I don't understand why. Right. So just the first part, the immunology, immunopathology and potential role of immunotherapy in COVID-19. So this graph is taken from a recent paper in Nature Medicine from a group in China. And shows the proportion of individuals over time who had antibodies to COVID-19 virus. In blue is the IgM seropositivity, in red is the IgG seropositivity, and yellow is the total G or M. And what you can see in this study is that by about 2.5 weeks after the onset of symptoms, everybody had detectable antibodies, the majority of them being IgG. Just as to note, all of these patients had been admitted to hospital, but some of them had relatively mild infections. So that's good news. Everybody seemed to have antibodies. But when we look at the data on which that is based, so each dot here is one individual patient, and the samples were collected over a period of time after the onset of symptoms. And in red here are the IgG responses. And you can see while some people had very high titers of antibodies, some people actually had very low levels. So whilst they might have been above the threshold for description as positive, they were actually quite low in many cases. The same is true for the IgM responses, and there's an enormous spread in the magnitude of the response. Something else that we're seeing over again now as the papers come out, that on the whole, people who've had severe disease, in the UK that would be people who were admitted to hospital, tend to have higher levels of antibodies than people who've had mild disease. In the UK, those people who were probably not admitted to hospital or certainly not admitted to intensive care. And this is something that's emerging, that antibody levels tend to be higher the more severe your disease and possibly the higher the level of infection, infectious virus you had. Nevertheless, it's also true that you can seroconvert to SARS-CoV without showing any signs of infection. And this is just one set of data taken from a pediatric renal dialysis unit, 13 patients, 25 healthcare workers, seen over a period of 3 weeks. These were children coming in several times a week for dialysis. And you can see that only one of the children was ever symptomatic and was PCR positive for the virus, and only one of the healthcare workers was PCR positive. Nevertheless, over a period of 3 weeks, 20% of the patients and up to 40% of the healthcare workers seroconverted despite being asymptomatic. This is just a little bit more detail on what these antibodies are binding to. So this is an antibody binding assay to the spike protein that I mentioned that binds to the cell surface receptor. And these are just titration curves for different individuals. And what you can see is that some individuals have high titers of antibodies that take a long time to dilute out, and others have relatively low levels or antibodies that dilute out very quickly. There is some cross-reactivity with the SARS virus. You can see binding here, but it tends to dilute out very quickly, suggesting it's low concentration or low affinity. And the same thing for binding to MERS. So there is some cross-reactivity, but not if you do a high plasma dilution. And there's no binding, for example, to HIV-1 virus. When we look at neutralization, as you can see here, so this is neutralization of the SARS-CoV-2 virus, and some of these antibodies have very efficient neutralization. They're neutralizing more than 50% of the virus at dilutions of 1 in 1,000, 1 in 10,000. And interestingly, those antibodies that cross-react with SARS and MERS do not neutralize. So the neutralization capacity seems to be very specific for this virus. Very interestingly, this same group have managed to isolate some human monoclonal antibodies from some of their patients with high titer antibodies. And each of these lines is just a different monoclonal they've managed to make, mostly from 2 different patients. These ones in red were deemed to be high affinity, high binding, high concentration. And what you can see here is that these monoclonals actually have very good neutralizing activity. And this is encouraging because if we can make large amounts of these antibodies in vitro, which is entirely possible, they then become potential therapies for treating cases. And that leads me on to this whole idea of convalescent serum or human monoclonal antibody therapy as a treatment for severe COVID-19 infections. So it's a variation on the use of antitoxins. We've used these for many, many years for tetanus, rabies, snake bite, and so on. And they've been used to treat pandemic viruses before. So in the 2009 swine flu pandemic, you may remember this product called ZMapp that was used in the West African Ebola epidemic. Small numbers of people treated, but very positive outcomes. And some use was made of convalescent serum in the SARS and MERS epidemics earlier this century. So the underlying idea is very simple. You have someone who's been infected and recovered from the virus. You take their blood, you check that it contains virus neutralizing antibody, and then you transfuse that serum into someone with severe COVID-19 and hope that they will improve as a result. There isn't much data on this yet. There's been a systematic review that's evaluated 8 studies, totaling 32 patients, and the data are consistent with reduced mortality, increased neutralized antibody titers, and reduction in viral load. But I do need to caution you, because there is a very high risk of bias in all of these studies. They weren't randomized. There was definitely some confounding, and the dosage and duration of treatment varied amongst the studies. On the positive side, there are numerous studies ongoing to evaluate convalescent plasma. At least 22 of those are randomized controlled trials, and there is 1 trial evaluating hyperimmune immunoglobulin. And these trials are proceeding at pace, and I suspect we'll have some answers quite soon. But antibodies aren't always good. So good antibodies in this case are neutralizing antibodies, but there are also bad and ugly antibodies. So bad antibodies in this context tend to bind to the virus but not neutralize. And then that antibody allows binding of the virus to the antibody receptor, binding receptors on monocytes and macrophages, and that can trigger the internalization of the virus into the cell and can actually increase target cell infection. And that's a phenomenon known as antibody-dependent enhancement of viral entry, and has been seen, for example, in SARS. Even worse, the ugly, is when this internalization process then goes on to trigger excessive inflammation by delivering the virus to the endosome of the monocyte or macrophage, where it triggers a wide range of innate receptors for viruses, leading to the release of pro-inflammatory cytokines. Now, the induction of an immune response requires a little bit of inflammation, so that can be good. But if this goes into overdrive, then it can contribute to the development of a cytokine storm, which is part of the very severe pathology that we sometimes see. So this potential for antibody-dependent enhancement or excessive inflammation is something we need to bear in mind as we start to evaluate the various vaccines that are in development. Another way in which antibodies may play a less than positive role is in the activation of complement. So there is some evidence that complement can play a role in the development of acute respiratory distress syndrome. This has been described in SARS infection, where the activation of complement components leads to the release of a pro-inflammatory cytokine called IL-6 from alveolar macrophages, and that can cause inflammation in microvascular beds across the body. Similar pathology has been seen in late-stage COVID-19, but I'm not aware it's actually been nailed as being complement dependent, but I might have missed something on that. If it is, then we do have potential complement cascade inhibitors that might turn out to be beneficial in such cases. So cytokine release syndrome or cytokine storm is well described for beta coronaviruses. They are known to infect cells of the immune system, including monocytes, macrophages, T cells and dendritic cells, and induce them to secrete interleukin-6 and other inflammatory cytokines. Cytokine release syndrome is a major cause of morbidity in patients with SARS and MERS, and they have very high concentrations of IL-6, which is a marker of severe outcomes. My understanding is that cytokine release syndrome is seen in patients with COVID-19 and correlates with high levels of IL-6, with respiratory failure, ARDS and adverse clinical outcomes. And certainly elevated serum C-reactive protein, which is driven by IL-6, has recently been shown to be a biomarker of severe COVID-19 infection. And if that turns out to be a major cause of pathology in a significant group of patients, then we do have some monoclonal IL-6 antagonists, including tocilizumab, which might be suitable therapies. There has been one report of the use of anti-IL-6 monoclonal for the treatment of severe COVID-19. The publication is shown at the bottom of the slide. So in that particular study, 25 patients with a variety of the familiar comorbidities received the anti-IL-6 monoclonal, but they also received other investigational antiviral agents. This wasn't a clean study. Nevertheless, their mean C-reactive protein levels declined very quickly. There was quite rapid radiological improvement. 9 patients at the time of publication had been discharged alive from intensive care. 3 had died and the others remained in intensive care. And there was a relatively rapid reduction in the amount of time that the patients spent on invasive ventilation. The majority did experience at least one adverse event, but it's not necessarily, it's not the case that that could be linked directly to the antibody therapy. So on the basis of this study, anti-IL-6 monoclonal antibody therapy was associated with a dramatic decline in inflammation, with radiological improvement and reduced ventilatory support requirements. But it's again important, this was not a randomized controlled trial, and therefore we need to be very cautious in interpreting it. But randomized controlled trials of anti-IL-6 are, as I understand it, underway. We've also heard in the press in the UK in the last couple of weeks about this hyperinflammatory shock syndrome in children, which has occurred at the same time as the COVID pandemic, and a high index of suspicion that it is linked to COVID-19 transmission. The first set of reports were published from 8 children presenting at the Evelina Children's Hospital in London. They were aged 4 to 14 years, and they had unrelenting fever with variable other symptoms, including rash, edema, and GI symptoms. They all showed the same progression to warm vasoplegic shock requiring supportive therapy and had no significant respiratory involvement. They had variable acidic effusions, elevated CRP, and various other markers of inflammation. Interestingly, they all tested negative for SARS-CoV virus on admission, but all subsequently tested positive for SARS-CoV-2 antibodies. They were treated with intravenous immunoglobulin, antibiotics, and aspirin, and the majority of them were discharged from intensive care within a week. Elevated cardiac enzymes are a feature of this disease in many children, and 1 child of the 8 died having developed an arrhythmia and a large cerebrovascular infarct. Currently, across the UK, there have been well over 100 cases. I saw a report today that there have been 100 cases in the US, 150 cases now summarised in the US. Here in the UK, the peak seems to have passed about 6 weeks after the peak of virus transmission, again suggesting that there is a link. In Italy, they've seen a 30-fold increase in Kawasaki-like cases since the start of the pandemic. And at the moment, my feeling is the best guess is that this is some form of immune complex mediated vasculitis, where the children have had an asymptomatic SARS-CoV-2 infection, have developed an antibody response, and then have developed some form of immune complex mediated disease. But the good news is that from the UK, at least, the vast majority of these children have done very well and have been discharged from hospital after a relatively short stay. A very interesting paper just published yesterday, and I nearly missed it, a study looking at reinfection. This is the question that people keep asking, can you become reinfected with this virus? So it's a study in rhesus macaques. They were infected, allowed to recover, and then reinfected 35 days later. This is the viral load in the bronchoalveolar lavage fluid during the first infection. You can see that virus peaked quickly and was cleared within 2 weeks. And this is on reinfection, and you can see very little virus in the lungs on reinfection. Each of these lines is a different monkey, and this is just a summary of the data on the right-hand side. There's a bit of a problem with doing this because you're putting virus in, and the question is whether you're just recovering the infectious virus that you put in. So another way to look is to use subgenomic RNA, which is indicative of viral replication. And here we can see in primary challenge, there was viral replication going out for more than a week, but on re-challenge, virus replication stopped within a week and was much lower than it had been in the primary infection. And there was also evidence of a induction of neutralizing antibody after the primary infection. So that's the only data I could find on immunity to reinfection, but at least in macaques, it looks as though there is some. So now on to the question of serological tests. So most of the serological tests that are being trialled are looking for antibodies against the spike protein. So the ones that were causing great consternation in the UK, we thought we'd got millions of them to roll out, and then it turned out we hadn't, are these characteristic lateral flow assays, where you add your sample that contains possibly some antibodies, it binds with the antigen, it migrates and is captured to identify whether the antibody is IgG or IgM. And typically you get a negative test where the control line is positive. In this case, an IgM positive would give you a line down here, an IgG positive would give you a line here, and both together gives you 2 lines plus the control. In real life, this is what they look like. So this is a study from China. So here we have the control line, a G positive line, and an M positive line. This sample here is negative, although there's a slight hint of an M positive line there. might be difficult to decide whether that was positive or not. This is a clear negative. This is a weak G positive. This is a stronger G positive, and this is a stronger M positive. In this particular study, the sensitivity and specificity of this particular test was way below the level that we would want before rolling it out, which has to be over 98% for both. So there's a group in Oxford led by Derek Crook that has been comparing a whole range of these different assays, all lateral flow devices, with a gold standard, which is an ELISA assay. So in this ELISA, pre-pandemic control sera that should be negative for antibodies to SARS-CoV-2 were indeed all negative. Samples collected during the acute phase of the illness on the whole were positive, although there were a few here that were negative. But all of these individuals were positive by ELISA after 28 days. So that's a nice, strong, good gold standard test. What you can see here, each one of these lines is a different assay. These should all be blue, they should all be negative. So these here are false positives from the test. And all of these should be orange, or certainly all of these should be orange. And what you can see is that there are blue lines here showing that these are false negatives in the test. And as far as I understand at the moment, none of these lateral flow devices have been found to perform at a standard that is acceptable for their rollout in the UK. But there is some better news this week. Two laboratory-based assays. These are variants of an ELISA assay. This first one has been developed by Abbott Laboratories. And in this case, this is the dotted line that shows you whether the test is positive. And just this is on a log scale, so you need to be aware of that. So these are our convalescent samples. The vast majority of them are positive, and these were collected by Public Health England either 14 or 20 days after the onset of symptoms. There are a few negatives here, which are probably early stage, probably 14 days rather than 21. They compared it with sera from some seasonal coronavirus cases, and they were all nicely negative. Some pre-pandemic negative sera, again, all nicely negative. And some sera that would be expected occasionally to give confounding results because of, for example, high levels of non-specific IgG in the serum. And you can see on the whole, this performed very well with very few of the confoundings giving false positives. So overall, PHE found that this had a 99.7% specificity and a sensitivity of about 94%. These were mild cases. Abbott's own data using hospitalized cases found a sensitivity 100%. So that's probably these few that are missing are either early stage or very mild infections. A very similar output from the Roche assay, which I understand PHE have done a deal with Roche today to start using this to screen healthcare workers. Again, the majority of convalescent sera are positive. There are some negative here, and they tended to be early. So we obviously need to wait at least 21 days and possibly 28 days before doing these assays. The confounding serum nicely negative, and the pre-pandemic serum nicely negative. And so, as I said, that assay has been endorsed by PHE, and I understand it's now been taken up by the NHS. So finally, on to vaccine development. At the moment, there are more than 150 vaccines in development around the world. There's a very nice app here run by the London School of Hygiene, which is tracking all of these and updating them. And if you go to that link, you'll be able to see all 150 laid out for you. The vast majority of those are still in preclinical development. There are 7 that have entered phase 1 safety trials, 4 that are in combined phase 1 safety, phase 2 early efficacy trials, or immunogenicity trials, and there's 1 that's that is in phase 2. These 150 are spread across all the different vaccine platforms that are currently being developed. So there are RNA vaccines, DNA vaccines, recombinant proteins, viral vectored vaccines, and then classical inactivated and live attenuated vaccines.
Alert.
And you can see here the vast majority are either viral vectored or protein protein-based. There are some attenuated vaccines and some nucleic acid vaccines. It's important to realise that with the nucleic acid vaccines, RNA and DNA, there are currently no existing licensed vaccines using this platform. And so I'm not entirely clear what the regulatory pathway for this is going to be. It won't be as straightforward, I would imagine, as for some other vaccine platforms. Viral vectored vaccines, there is one for VSV, and so the regulatory platform for that at least there is a proof of principle for how that would be done. Recombinant proteins, live attenuated and inactivated vaccines are widely used now, and so the regulatory path for those should be relatively straightforward. So just 3 examples of data coming out of those trials, all of them from non-human primate studies in rhesus macaques. The first one is an inactivated vaccine, inactivated with beta-propolilactone, alum adjuvated, given by 3 intramuscular vaccinations at 2 different doses. And what you can see here is that you get good antibody titers in terms of ELISA binding. You get neutralization at a titer of about 1 in 100. These are the control monkeys. You get reduction in virus RNA in the throat swab, particularly with the high dose vaccine, less good with the low dose vaccine. And you get reduction in virus in the lung. And importantly, there was protection against pneumonia. So these are the, this is pneumonia in the placebo monkeys. These are the vaccinated monkeys that didn't get pneumonia. I'm not quite sure, it doesn't say in the paper what these were. But the take-home message is it prevented pneumonia and reduced but did not prevent virus shedding. The next one is the one that you've probably heard a lot about. This is the one that's being developed in Oxford. It's a recombinant chimp adenovirus with the spike protein inserted. It's given as a single intramuscular immunization, which is obviously good in terms of the ease of rolling out this vaccine. They vaccinated 6 monkeys, had 3 unvaccinated controls, and challenged them with high-dose virus. Again, it prevented pneumonia. There was no immune-mediated enhancement of infectivity. There was a reduction in clinical signs, that's red compared to the blue here, the control monkeys. And there was a reduction in the amount of virus, and this is particularly the one to look at the amount of active viral replication compared to the controls. But there was neutralizing antibody, but there was definitely virus replication. And lastly, one just published again yesterday in Science. This is the only one that's been through peer review at the moment. The other 2 were preprints. And this is a DNA vaccination in rhesus macaques, 2 intramuscular injections. They reported but didn't detail the clinical symptoms, and they said they were mild. There was no detectable virus replication in 8 of the 25 vaccinated animals. You can see here the reduction in viral load. These are the sham vaccinated, and this is one particular construct which had very good virus suppression both in the lung and in the nose. And they found that vaccine elicited serum neutralizing antibodies seem to be relatively good correlates of reduction in viral load. So if you are intrigued by the vaccination trials and want to get involved, there is an opportunity. NHS Lothian hospitals are set to become a major site for testing of the Oxford vaccine. They're aiming to enrol about 600 frontline health workers, and details of this should be released tomorrow to begin screening on Monday. It'll run out of the Western General in Edinburgh and the Royal Infirmary, and the PI, Dr. Becky Sutherland, is on the call. So if you've got particular questions for Becky, you might want to follow up with her, and you can get information if you want to volunteer at this website here. And with that, I will stop. I want to make 2 acknowledgements. The first is to this fantastic website, immunopedia.org, which is run out of South Africa, and Clive Gray from Cape Town University has been doing an absolutely fantastic job of trawling for all the new papers and summarising them and putting them on this website. And my other regular source of information is the Science Media Centre, led by Fiona Fox and her sterling crew, who every day are sending out updates on the latest developments on COVID-19. And with that, I will stop, and I'm very happy to answer your questions.
Eleanor, thank you for that. That was a fantastic run through the evidence that we have today in such an evolving field. We do have a number of questions on Slido. I obviously can't take them all in the interest of time, but picking up on some of what you said, we've got a question about the possibility for a second infection. We've obviously got the antibody research in monkeys. Are we right in thinking that can be extrapolated to the human condition, or is this a situation like influenza where COVID-19 may mutate so our protection does not last?
So the evidence so far on coronaviruses is they're much less variable than flu. They don't evolve as quickly, and they don't go through the recombination that flu does, that tends to lead to massive changes in antigenicity. The COVID-19 vaccine is mutating. It's mutating very slowly at the moment. So if reinfection occurs, it will probably be because the immune response is not very effective, rather than that there's a new virus in circulation.
Thank you. And another question about the herd immunity question. Obviously, that did hit the headlines. Where do you think we are with that concept?
So the short answer is I have no idea. The good news about the NHS doing a deal with Roche to start doing some antibody testing at scale is that we will begin to find out roughly what proportion of people have had exposure. And obviously I think that's going to be focused on frontline healthcare workers first, and knowing that they are high-risk population, so knowing what proportion of them have had the virus will be helpful. Eventually we need to roll that out to the population, and then we'll know whether it's 5% of the people have had the virus, which is about what it seems to be in the UK at the moment, or whether it's much higher than that. And because these asymptomatic infections can cause seroconversion, it is possible that it's higher than that.
And carrying on from that, we've got a question about whether we should be thinking about immunity-based licenses or immunity passports, as they're being nicknamed. Is that a valid way forward?
I think it might be in the future. I think it's premature at the moment. Because we need to build up an evidence base that says that if you have antibodies, you are not going to get reinfected. And actually, I think the data from the healthcare profession will be very helpful there, because if we know that people have got antibodies and they go back into the front line and are treating more patients and don't get reinfected, then that might be some evidence. But now that we've got really good PPE, one would hope that that would happen anyway.
Yes, I think we should stay away from the PPE question tonight.
Yeah.
Eleanor, I think it's credit to your talk. We've got a lot of questions coming through on Slido, and I'm very sorry that I can't take them all in the interest of time. So I hope you don't mind that we ask you to look through them, because we do want to capture some of those responses. But can I thank you for a lovely talk tonight. I hope you'll be able to stay with us and listen to our next talk, which is much more practically based, but that run through was very helpful indeed. Thank you so much.
You're welcome. Thank you.
We have got Pauline Wilson online, and I think we are waiting for our colleague, so I'm going to introduce Pauline herself. Many of you will know her, and some of you will be aware that Pauline has been dealing with a surge of cases in Shetland, and obviously brings that experience to us tonight. She's here with her chief executive. Michael has worked in other areas of healthcare and has actually worked fairly recently with a Getting It Right First Time programme, which looks at variances in care He is a nurse to background, which is slightly unusual in a chief executive in our NHS, but they're going to do a two-handed talk, and without further ado, I'll let Pauline get started.
Can you see those slides, Jean? Is that fine? So thank you very much for the opportunity to share our, I suppose, a human story with you tonight about the Shetland experience of dealing with COVID-19. So I speak really on behalf of the remote and rural areas in Scotland as to how we've adapted and had to cope with this virus, out with, I suppose, the bigger centres. So thank you for the opportunity for us to share this experience with you. So for the audience, I thought it would be worth just sharing with you about where Shetland is, because often we're not placed appropriately on maps. So Shetland is an island that's within the North Sea. We straddle 60 degrees north, and we're actually nearer to the south of the Arctic Circle than we are to London, our capital. Shetland's tertiary referral centre is Aberdeen, and so for any patients that require ongoing specialist care in our tertiary referral centre, our patients are transferred to Aberdeen. And Shetland's equidistant between Aberdeen, which is 200 miles south of us, either by flight or by boat, and it's equidistant to Bergen in Norway and also to the Faroe Islands. So that's where we sit in terms of our geography. So I think we do have the badge of honour as being remote and very rural. So in terms of the Scottish government classification of what remote and rural is, if you look at this map, if you can see here that the blue areas are where our population density is largest, and if you look where Shetland sits, it doesn't actually sit off the east coast of Scotland, and it's really important that we put Shetland in its rightful place, because in terms of policy, in terms of planning, it's really important that we actually get Shetland to where it is, because sometimes when we're planning around healthcare provision for a remote and rural area, it is best to get the perspective of where these areas are. And as you can see, a lot of Scotland is that dark green, so would be defined as being very remote and rural. And why is that important? Well, it's important because actually it's quite a large landmass in terms of our Scottish geography. We have quite long travel times for our patients to access tertiary care. Often our GP practices are single-handed practices, and that brings with it particular challenges around this time of virus. And also, as we've all had to think differently about our infrastructure and connectivity, the more dark green areas of Scotland can be sometimes the worst served in terms of that connectivity with infrastructure. So it's important that we put our rural areas in perspective. So when we're planning policy and we're planning developments, that we also think about where our population is based. If we then look at what the definition of a remote and rural hospital is, well, there's 6 based within Scotland. So we have the Gilbert Bain Hospital at the far north, we've the Balfour Hospital in Orkney, the Western Isles Hospital, we've got Oban, Belford and Caithness Hospital in Wick. So those are the 6 rural hospitals that are scattered throughout Scotland. And also when you speak to our colleagues that are down sometimes in the borders area and away from the central belt, they can sometimes feel equally remote and rural at times, and that's quite an interesting concept to bear in mind. So Shetland is an archipelago of 100 islands, so we're islands within islands. Most of our population is situated in what we call the mainland, but we do have 15 inhabited islands that we have to look after in terms of provision of healthcare. And if you look at the far north, we have the most northerly island of Unst. So if you live on Unst and you want to access healthcare within Lerwick, that's going to involve an ambulance journey or a helicopter journey if you're very seriously unwell down to Lerwick. And that will involve 2 ferry journeys and can take several hours for a patient to get from Unst to Lerwick, which is where our secondary care centre is based. Some of our other islands have no doctors on them and have nurses on them, so they've had to use technologies for many years now in order to access help and advice. And just some of our history, if you look here, we've got lots of history in Shetland, and we have more puffins than people. So if you want to come to Shetland and see the puffins, not at the moment, I hasten to add, there's 1 each for the head of population. So there's about 22,500 of us. We also serve the North Sea, and we have quite a number of medivacs off rigs, and we also have quite a lot of transfers from boats that working in and around the Shetland Seas. The Gilbertbane Hospital is our base here in Lerwick, so we're very traditionally set up in terms of what most remote and rural hospitals will look like. We have a medical ward, we have a surgical ward, we have a small provision for HDU type care, which is housed out of our surgical ward. We have a very busy active day surgery unit, a small maternity that deals with the more uncomplicated end of the pregnancies, and we have an A&E and resuscitation area. We have limited diagnostics, but we do have access to X-ray and ultrasound, and a CT scanner, which we got on Shetland in 2007. When I started my post here in 2005, we didn't have a CT scanner, and we were having to transfer more of our patients off island for diagnostics. The Shetland community at the moment are trying to raise funds for an MRI scanner. But as we came into COVID-19, one of our main issues, and I suppose throughout the rural Scotland, one of the main issues is that our hospitals are quite old. At Orkney, the Balfour Orkney is just a brand new hospital, so they're better off than we are in terms of facilities. But we in Shetland have 8 single rooms, and we have no intensive care unit. And so coming into this pandemic, some of our wards, our surgical ward is really a pretty classical Nightingale type ward. So this was a real consideration for us. In context of our team is a small team, made up or led very much in a consultant-led model. So we have physicians and surgeons and anaesthetists in our hospital setting. We have a number of visiting services in terms of either remotely visiting, in terms of attend anywhere type consultations with, for example, neurology services set that up very nicely, but we've also got a number of visiting services to the island. We've 1 middle grade surgeon, but we don't have a middle grade rota, so we don't have that specialist trainee tier, and we run with 12 junior doctors who support our front door as well as our wards. And so we've a combination of our junior doctor rota running from an FY2 grade up to a core medicine trainees or internal medicine trainees. But we have that, I suppose, that lack of that specialist trainee support structure. I think this slide sums up how we feel. I couldn't really put this into words any better. So we tend to see our specialist colleagues as the maestros. So they are highly skilled in their field and have a great knowledge of a particular area of medicine. As a generalist in a remote and rural setting, we are very much feel like sometimes we're the rag and bone man. So we have to be able to dip into the toolbox and have a breadth of knowledge, but maybe not that depth that our specialists bring to the table. But we do have to cover all eventualities. So we have a totally and true unselected take. So that is from the neonate who may present to the octogenarian and everything in between. So we have to be able to deal with that at their front door and then either look after that patient in our own ward setting or decide whether we're going to transfer that patient off island. When I arrived in Shetland in 2005, our transfer of island, so transfer is a really important part of how we think about our patient journey. So when I arrived in Shetland in 2005, it was a Loganair. It was the inter-island Loganair aircraft that was involved in the transfer or retrieval of patients to our tertiary referral centre, and the staff that used to go on that was us. So I would find myself not often being called on to transfer a sick patient to the mainland. Our anaesthetic colleagues would often transfer the more unwell ITU type patient. So really our transfers have come a long way. So over the years we've seen the air ambulance service, and that's been a fantastic development. And then we've also seen the development of retrieval services. And I can tell you, you know, that retrieval medicine and that safe transfer of the patient is a skill in itself, and we're really grateful for our colleagues that are involved in retrieval medicine. When they arrive on island after you've been dealing with that case for several hours, there is a tangible sense of relief, I can tell you. But not only do they help us with transfer, but they also help us with, you know, the journey of that patient while they're in that critical phase. So it's a very good relationship that we have. I'll pass over to Michael.
Good evening. My name is Michael Dixon. As you've already heard, I'm a nurse by background. This is my first chief executive position, and I felt myself very lucky to come to a beautiful place like Shetland and take on the opportunity of leading what is a comparatively small board through what I thought would be a fairly normal period of time. Now, usually when you start a job, you take your time, you get to meet people, you get to meet how the service is done, and then you can think about how we can deliver change and transform services. So one of the big differences in NHS Scotland versus England, and you might have noticed that I have an English accent because I spent most of my career working there, is that it's far more collegiate in Scotland. Chief executives meet every single month. We talk about strategy, policy changes, things that might be affecting the NHS in Scotland as a whole. So I'd started to get into that tempo, the rhythm, going across to Edinburgh, meeting with my colleagues. And then suddenly one of our agendas was wiped away. We were told that we were meeting for a particular issue. At that time, it was known as coronavirus. In what was, I can only describe as possibly my worst day in my entire career, we were briefed that this virus was about to rip through the Scottish nation, that we would lose thousands of people. And I sat there for a moment and just took a sharp intake of breath, because I'd been here for a matter of weeks. I would be going back to a community and explaining to them in no uncertain terms that this was something that our health services would be overrun with, that we would lose and they would lose as a community, hundreds if not thousands of people. And how could I do that? How could I communicate that to a population that this was not what they were expecting as the chief executive? So I wrote to, emailed through to my executive colleagues, explained the situation and what we were facing. It was important that we took the moment to pause and just think about the impact of this on health services in Scotland, but particularly in Shetland, because this was unlike anything that anyone had experienced before. One of the first questions that Scottish Government asked us was, how many additional beds could you create through surge capacity? And the answer I got back was 4. And I can't stress to you, being faced with a situation where I'm expecting to tell a community that the people are going to die, to say the only thing that I can offer is 4 additional beds. It was no lie. I put my head in my hands because I didn't know how we'd be able to get through this. But, you know, that's the moment in time, and that's where you just reflect upon things and go, okay, well, look, we need to do things differently. We need to think about what the art of the possible is, the changes we can make. So we set up a battle rhythm. We knew that this would be about a command and control approach. We set up our pandemic meetings. We addressed challenges head on. And we knew we had to make decisions that weren't just about NHS Shetland, but about the whole of Shetland. Because our response to this as an island, as you've already heard, a long way away from the mainland, we are at the end of the supply chain. We've got to think of critical issues such as transfers, how we get supplies. You'll hear some of the other challenges in terms of the clinical response. But fundamentally, something as basic as personal protective equipment, that was under challenge across the whole of the nation. So we set up a personal protective managed service for the whole of Shetland, not just NHS Shetland. No barriers between acute or community, no barriers between social care and NHS, but fundamentally one that can be accessed by all of Shetland. And it was a start of something that really has transformed over an incredibly short period of time, not just how we deliver our services, but also how we move through the future of how we deliver services. But for me personally, having gone through what has been an incredibly short space of time, a huge amount of transformation, and facing that challenge, I have to say it was daunting. It was daunting for each and every single one.
So Michael's kind of outlined where we were as a community, and while all this was happening, we had to think about our clinical response. So some of our staffing challenges were very real to us. We have no middle grade structure, and while larger centres were starting to talk about redeployment of junior trainees from one area to another, and talking about moving staff around, our ability to do that was zero. We had no real capacity to redeploy. And also when there was a national call for return to practice, again, that wasn't something that was going to be of benefit to us in any huge influx of practitioners back in to help us here in the Gilbert Bain Hospital or in the community. I think the moment where I realised that this was quite serious for us is when we out of our 12 junior doctors, we through not direct COVID, but COVID indirectly reasons, we lost 5 from our rota really quickly. And we had also a little bit of a battle on our hands in terms of the fact that we were 2 posts down in terms of rotational posts, and we had to really work hard with our with NES and the deanery to secure the transfer of those staff from centres to Shetland, and it took quite a number of days into weeks to sort that issue. But we still had to rely, in order to staff our junior doctor rota, the appointment of locums. And the other thing that's really pertinent for us was the fact that we've had difficulties recruiting senior staff for some years now, and we've had to go to another model of providing senior support in our hospital structures, and that has relied on overseas medical staff. So they come in for periods of time and support our staffing models, and then rotate on a leave basis. So they'll be here for 2 months and then go for 2 months. And we were suddenly aware that we had some of our staff overseas, and could we move them, and when could they come? So this was a real challenge for us going into this pandemic. So staffing has been a challenge for everybody, and we don't underestimate that, but we had particularly unique challenges within the remote and rural setting. And we've had to evolve as a team. So one thing about older hospitals is office spaces is really small. And our corridors are 1 bed space wide, and our lifts can only take just about take a nurse and the bed into it. So our hospitals is not designed for modern sized equipment. And we were really aware that if we started to not socially distance as a team very early on, that if we were to become infected or develop the virus, we could actually affect our whole team. So we had to put in place really early on that concept of the social distancing ward round. It had to happen. So we trialled it in a room where we all sat apart, and it didn't work really very well, as you can see, because we couldn't actually see the screen. One of my colleagues came up with a novel way of managing that. We then had the issue of personal equipment that Michael's highlighted, and getting to grips with how we use that within our clinical settings, and what was our red pathway, what was our green pathway. And we've had to move really quickly to using Microsoft Teams in order for the team to come together in the morning, do our general what's happened overnight, split our duties, divide up the day, and then come back as a clinical team around about 11 o'clock through Teams again to then discuss where we're at with our patients and where we are at with our flow through the hospital. And that really has been the only way that we've been able to manage that. I think we were just all mindful that we had a responsibility to keep well and keep our colleagues well. And if we had been in a room with somebody else, not be a contact. So we've had to try and evolve as a team really quickly. In terms of how you come into the Gilbert Bain Hospital, the way we work is our accident emergency is our front door. It's how everybody, apart from our day cases, come into our service. So either NHS 24, your self-referrals, GP out of hours, or in hours, and obviously our 999 services come into the hub, which is our accident emergency. And the staff that manage that accident emergency are the same staff that manage the wards and manage the outpatient clinics. So we have had real challenges in separating out red and green pathways in terms of our healthcare workers, particularly our medics. Our nursing staff are possibly a little bit better off in terms of separation, but in terms of our medical staff, that's been quite a challenge for us. And also not having that dedicated admissions unit that we could quickly turn red was something that we've had to grapple with. And we've, like every other hospital throughout the UK and throughout the world, have had to think about flow of patients and red and green pathways. And that's for smaller hospitals. I'm not taking away the challenges of larger hospitals as well, but for a particularly small hospital with 2 wards, separating out patients into pathways of care where you've got a multi-purpose ward is actually a major challenge. So we have 8 single rooms. We have multi-purpose wards that look after the medical surgical patient. We have patients recovering from strokes on our rehabilitation pathways. We have patients who present with acute mental health crisis. And we also have our paediatric inpatients who we look after before either sending home if they're well or transferring off island. So how we were to develop our red and green pathways into this kind of model was a real challenge for us. And the other thing that we had was a lack of negative pressure rooms. There was really nowhere within the hospital when we first started looking at it was truly negative pressure, and I have to say hats off to our estates colleagues. They've worked tirelessly to create environments of negative pressure for us in a very short space of time. And I can tell you as a clinician, I know more about flow rates around this hospital now than I ever thought I would know. Part of our clinical response, all our oxygen is shipped into Shetland. So while we were coming to grips with the number, so when we first were told it was for every intubated patient, you can expect around about 5 on CPAP, and then behind that 5 is another 30. And that for us was a major, oh my, what does that mean in terms of staffing? But what does that actually mean in our ability to look after these patients? Because when we initially started out, we were told our flow rate of oxygen was 100 litres a minute. Now, it doesn't take an imagination to see how quickly that would be overwhelmed. Our technicians have managed to get that up to 160 litres a minute, but as you can see, that really doesn't give us much capacity. And also we need to ship in our oxygen to Ireland, so that had to be factored in. So one of the things we had to do was bring in oxygen concentrators. so that if we were overrun with COVID, we would have some backup in terms of oxygen provision. And I think the moment of disbelief as a clinical team was the day that we were told, well, you have no on-island testing facility, and actually the only way to get your patients off island is to know that they're negative in terms of COVID. Now, we have moved on from there, but that message was the initial message. So at that point, as a clinical community, we looked each other in the eye and thought, well, that means nobody's moving, because if you can't test and you need to have a negative test before you transport, well, what does that mean for our Shetland population? How are we going to manage? Things have improved since then, but as we came into this, that's exactly what we were told, or what we thought was our situation. And then our first cases arrived in March, and being in a small community, the one thing we've had to deal with really quickly is the fact that before things are reported in the news, it's all over Shetland. It's just one of those communities. So you're hearing, oh, this is happening before you've actually really grappled with what actually is going on. While we were coming to, I suppose, to set up our testing facilities, that meant testing and then sending that off island. We were waiting 3-4 days, up to 5 days sometimes, for those results to come back. We were trying to get our heads around what that meant in terms of our local response. And I think this is where the Shetland community spirit really does come in. So in Shetland in the summertime, we have nearly endless sunshine. So in the summer, it's a nice place to be. In the winter, we need to come up with ways to keep ourselves entertained, because we have long days of darkness. And one of the things that we do in January is there's a big festival called Ophelia. And Ophelia is where our communities come together, and we have a Viking type celebration. That brings in people from all over the world. It also brings thousands of people together in small spaces. Our main event of Ophelia is held in January, and it was quite interesting. In January of this year, after our main Ophelia event, so these are a squad of men who are dressed as Vikings, beautiful suits. They visit schools, care homes, and then there's an all-night party, which involves hundreds of people. But after that event, there was quite a number of unwell people with a virus, and whatever that was is not fully known, but there was quite a lot of people unwell with the virus, and but our community understood really quickly that actually these big events are events that will spread disease. So we had 2 further Ophelias in March, and our community came together and decided, after speaking to health board personnel, that actually the best thing to do in terms of the community response was to cancel these events. And that's a fairly big deal in our community. It's probably the biggest news that you can imagine. And also at the same time, Shetland, we had quite a number of youngsters affected with the virus early on, and we had 300 plus pupils off school. So before Scotland mainland shut down their schools, Shetland schools decided to close for a week to evaluate the situation. So Shetland probably shut itself down before any other area, and at that point we had more COVID cases per head of population of anywhere in the UK, and we were trying to grapple with that with lack of staffing and pathways we were trying to set up. And it's not lost on me that while the Shetland community understood what this meant in terms of their community, so losing thousands of people, when you know all those people, or you know your community quite well, it's quite harrowing. And so when our streets were empty, this event in England happened to be taking place. And this time will tell what the best response was, but that is the juxtaposition between what was happening in our community, which had really grasped that actually we are in this together as a community, and we need to get this right and protect our health service, with what may have been happening south of the border at that time. Our first hospital case, everything happens, doesn't it, on a weekend? Everything happens after 5 o'clock, and that's exactly what happened with us. So Saturday night at 7 p.m. We got our first case. One of my colleagues contacted me to tell me that that we had our first case, and quickly followed by we've got another one and then another one. So that the patient was 10 days, positive patient who was 10 days post positive result. And they really, it was very evident they required critical care support very early on. So I'll hand over to Michael just for the last bits.
So Pauline's already mentioned the well-oiled machine that transfers patients between the Gilbert Bain Hospital and across to Aberdeen. But we were in uncharted territory at this point because we had a known COVID patient, and so the normal conversations that took place about transferring a patient had to take a different change. And you can see on the slides, our normal, very small air ambulance transfer had to be replaced with something significantly larger. This is an Atlas plane that the Royal Air Force supplied to transfer a patient, the first COVID patient, from Shetland to Aberdeen because they were ventilated at the time. Now, those conversations that took place at a clinical level were being replicated at a government and board level because this was unprecedented. We hadn't done this before, we didn't know how we would do it, and the pathways were still being worked on as we were going through. The process of this has been called a MACA, Military Assistance to Civilian Authority. And I have to say, as the accountable officer for NHS Shetland, I'm very thankful that we had military assistance. We have military assistance now. We have 2 military liaison officers working with the health boards, and they've been hugely useful. But this point of crisis was important for us because it meant that the Royal Air Force were able to transfer safely and effectively a Shetland patient from Shetland to Aberdeen. Just for information, this requires sign-off from the First Minister. My understanding, and whilst it may not be entirely true, but I'm going to go with it, was that she was woken up at 2 in the morning to sign off this MACA request to enable this transfer to take place. But again, it was one of those key points where you look back and go, okay, this is time where we can learn from this. And whilst we had a second transfer using a RAF asset, and a huge thanks to the Royal Air Force for doing this for us, the fact is that we've got better each time this has occurred. And so now we have clear pathways in place with Scottish Ambulance Service. So we should be able to transfer any COVID positive patient who is ventilated using normal equipment with modifications to enable that transfer to occur. But this was huge news in Shetland. Military aircraft don't normally land in the very small airport at Sunborough at the very bottom of Shetland. As Pauline mentioned, this was on social media quicker than we could possibly imagine. And people were talking about it. This photograph was taken by a local plane spotter who, this is big news. So, as much as we try and engage with the media and control, the fact is that the population will know about it far before we start talking to them. So Shetland, understandably, being a small community, is information hungry. Obviously, the fact that we were a focus, and often a global focus, we were a small island with some of the highest cases that you'd expect to see for population. So we took an approach which was about being open, honest and transparent. We didn't think there was any other way to manage this. We talked to our print media, which is the Shetland Times, Shetland News, which is our website. We engaged with BBC Radio Shetland, and it was about being open. Some of the stuff that we didn't know about, we would say we don't know about it. We were upfront and honest with the community. We talked about how bad this would be. We tried something that we hadn't tried before, which was doing a Facebook Live broadcast. So on my Facebook, Michael Dixon's Facebook page, every week we do an hour-long broadcast to the general population about what's going on, what the numbers are, and try and steer them away from this real obsession about the numbers of cases. We understand exactly why there is a real focus on it, but there's wider issues. And as part of that, we talked about the challenges of having a ventilated relative. Would you really want that for your relative if they were sick? It's a traumatic event. We were open about it. We talked about anticipatory care planning. We have had 7 people who've sadly lost their life due to COVID-19. But the vast majority of those had underlying conditions, and all of them had anticipatory care plans in place. So because our care homes are different in Shetland because there are 10 of them, and they do everything from nursing to rehabilitation and end of life care. So we're able to work with those care homes, but more importantly, we're able to work with the community to help them have those often really difficult conversations about resuscitation, ventilation, end of life care. And the community responded to this positively because they guessed, and we had no other way to do it. This was about us being honest. This was about us being transparent and actually taking those messages directly to them through no filter. There was no trying to spin this. This was exactly as we found it. And they wanted to help, and in a true Shetland style, their response was fantastic. We didn't think that volunteers would necessarily be the right place to go, but the Shetland community is incredibly crafty. I don't mean that in a bad way, but I mean in terms of they knit, they sew. It's astonishing. So our staff were rapidly moving into scrubs, and this was an ideal opportunity for the Shetland community to help. And they really came up trumps with this. So we had hundreds of people. They donated the young lady on the bottom right-hand side, donated her One Direction bedspread to be turned into scrubs. And what it really helps is it helped the staff in the hospital because we needed scrubs in short order to turn this around. Our scrubs are laundered centrally. This was a way that they could really make a difference. Some of these are very sought after designs. The licorice arslet one in particular is hugely sought after. But this is about the Shetland community giving back to the NHS, contributing in a way that was really meaningful to them. And I have to say, it lifted morale greatly, and it's something that they should be hugely proud of. And it made a difference. We're now rolling these scrubs out to our care homes as well. So again, we have that centralised laundry system, but it was a way the population could really make a difference to their NHS. So this is the Shetland flag, and I appreciate I've only been here since January, but I want to take a second to talk about the Shetland privilege. I'm proud to be part of a community that is able to respond in the way that they have. It has been overwhelming. People have been welcoming, people have been kind, people have been caring. But living in Shetland gives you something unique, which is the ability to be able to revel in the beauty and the nature. That's not just puffins, that's Wales, that's Shetland ponies, that's beautiful scenery, but also it's easier to socially distance in an environment like this. You might go for a run and you might run into 3 people. So it gives us a real opportunity to do something different. And I think we're proud to be part of a community that has done that, but proud also to have a community that's responded to this crisis in the way that it has. And that includes, because don't forget, the clinicians, the nurses, the allied health professionals that work here are very much part of the community. So their community response to this pandemic has been immense.
And just to finish up, I suppose I'd like to ask the question of us all, what's your silver lining within this dark cloud? And I think that's a really good thing to stop and think about. Is there something that defines that for you? Well, for me, I'll tell you what it's been. It's been our medical students moving to our FIY1. So we had 6 medical students in Shetland. We knew very quickly that graduation ceremony for them was not going to happen. So we were able in our small island hospital to do a virtual graduation ceremony in Viking style. And that was a really special moment for us, being able to welcome these medical students into the workforce, and our community totally got behind this as well. I think these, our 6 new FI1s must be the most recognisable people within Shetland at the moment. So for me, the dark cloud of COVID has very much been underlined by that spirit of coming together to try and solve this issue as a team. And lastly, so where are we going in terms of our future? So one of the, contact tracing program is probably the biggest thing that is newsworthy at the moment within Shetland. So our Shetland community are really asking questions about, well, how can we come out of lockdown and what does that mean in terms of contact tracing? In terms of new models of working, what we want to do is expand that technology that we use. So we use Attend Anywhere. We've been using that for a number of years very successfully with our Roual, with our furthest away islands. We've also linked in by teleneurology clinics to Aberdeen and provide other teleneurology services. So what we really want to be able to do is expand on that. So we feel we're in rural areas slightly maybe ahead of the game in terms of using this technology to access our patients, and we're looking at ways that we can enhance that. I would be keen to look at, and we're going to pilot a study where we're actually going to use our Attend Anywhere type platform to link professionals, so professional to professional. So our diabetes team is about to become virtual, and we're going to start to outreach through June into 2 sites within Shetland to provide a team approach to patient care and see if we can help support our general practitioner colleagues, keep people possibly at the home if need be, and support that pathway. So we're going to use Attend Anywhere slightly differently in terms of trying to use the professional to professional link and then see how that goes. And also, as we recover here in Shetland, we need to be very well aware that we're not recovering alone. So we have to recover very much with our partner board in Grampian, because a lot of our services are visiting services, and a lot of our patients require travel to Aberdeen. So we're not only going to be able to recover services in Shetland by ourselves, we're going to have to link in with our larger board in Aberdeen. And I think one of the things that's dominated the conversations today is how we will continue to manage the very green pathway, the green pathway and the red pathway going forward in a small hospital. So not just for a few weeks, but for many months ahead. It is a privilege to be part of such a community and provide healthcare to a population. I think the thing that doesn't go away is the fact that you have to treat patients that you genuinely look in the eye as you go shopping, as you bump into them on the street. So we have a real, I suppose, sense of the fact that what we do actually has a big impact on the people that we live and work alongside. So thank you for your time and thank you for listening. It's been a privilege to tell you our Shetland story.
Pauline, Michael, that was a great run through of what it feels like to be living and working in a close community in a time like this. And I'm very sure that will resonate with some of our listeners tonight who are working in other remote and rural areas. Many of you will know that remote and rural medicine is a real area of interest for the college, both in Scotland and in other nations. So your experience will be very relevant to that learning. We do have a few questions. I'm conscious that you definitely deserve to be listening to the Clap for Carers with all the hard work that you put in Shetland, but I'll ask a couple of them. One of them is asking about how do you think the internationality of the workforce in Shetland, particularly with your oil and gas workforce and the links with Grampian, Norway particularly, and Shetland, what do you think that has in terms of linkages and contact tracing? Is there anything there that you've considered?
I mean, I think for us, one of the biggest issues is our workforce in the hospital at the moment. So, and that will go across not just healthcare, but other sectors of workforce within Shetland, is that we have a big reliance on that worker that comes in. And we have staff that come in and do 8-week blocks. Now, if we introduce quarantine and have no other thought process around it, our model of healthcare provision in Shetland falls apart really quickly. So in our anaesthetic service, we have one consultant that's on island and the rest of those anaesthetic colleagues fly in. Within our medical service, we have a reliance on some colleagues from India, and also within our psychiatric service and in our obstetric service. So this is probably one of the areas of major concern for us at the moment. So how do we get this right in terms of articulating that message up to policymakers that we really do need to consider this, because we could uncouple and destabilise our services really quickly if we cannot have that movement and have a testing around about our workers coming into Shetland, and whether that then moves from healthcare into other sectors. I think that's something we really do need to look at, protecting our community, but also having the ability to serve our community.
And Michael, I think you particularly articulated the connections with the community. So telemedicine is well established in Shetland, but you've talked about the links across primary care and your no barriers attitude to this. So picking up on the silver linings to the cloud, what do you envisage coming out of that in terms of the links of the hospital with that community of practitioners around it?
I think there's a real ambition, and it's not a top-down ambition from the chief executive saying we'll do it like this, but there's a real ambition from all of the clinicians, regardless of where they're based, to say we can use this as an opportunity to do something different. And it may be about the way we handle our patient requests, it might be about the way the patient flows move across between our various expertise, and there is expertise across the whole system. And I think this is about where the board leadership comes in. It's about how we enable that to happen, rather than say, well, we've got a very rigid approach to this. This is the only way we can do it. I think it's how do we capture those talents of those clinicians to go, yes, of course, now let's find a way to make this work. So the example that Pauline was given about having a virtual diabetic clinic, the idea that expert doesn't mean that the patient travels to the expert. It might be a way of reaching into a GP surgery and augmenting some of the services that are delivered there. It might be using different practitioners, and again, under the direction of a whole range of services, rather than it just being focused on a one-on-one relationship.
Yes, and I think that idea of finding where the skills are and ignoring the false barriers that we've placed is the way forward, isn't it? Both digitally and with direct conversations. I'm conscious of the time because we're now just coming up to 8 o'clock, and I want to thank you and Pauline and Eleanor as well. We've had a very interesting evening moving from theoretical into practical. And to those of you that are listening, please remember that you will find these recorded. I'm sure some of you may want some more questions answered. We've still got Slido open, and I'm sure Michael and Pauline will be able to look at those in due course. It is very practical experience, and that's the point. We wanted to be able to give you ideas of what the positives are coming out of such a locality-based experience through these recent weeks. We now are going to close, but please think of joining us again in our next one. I've already told you who our speakers are going to be, and thank you to everybody, and get out and clap for carers. Thank you so much, and good night, everybody.
Bye-bye.